and my dear Iva Milinkovic, scientific co-host of the night. Thank you for being back. Here's a new format. We'll address 4 different questions, and for each of them, you as an audience member will be able to vote whether you think it's true or false, or you don't know. And the voting is done in the same way as during the battle. You can scan the QR code, which is now on screen, or scan that little QR code, which is right down the live stream player in the platform. So, Eva, what is our first question of the night, and who will be addressing it?
So, long time no see. Let's see whether it is true that ceramic customized implant abutments perform better aesthetically than metal implant abutments. Dean Morton from USA is going to try to answer this question.
Is it true? Do customized zirconia abutments or shaped tooth-colored submucosal components? So what are we really looking at here? Firstly, we are looking at the tissues themselves. What we really want is the right shape and the right color of the tissues. The right shape is associated with curvature, support for the tissues, presence of papilla. These factors are related to the submucosal form of the restoration, in this case, the abutment. It's also important to note that zirconia is a very tissue-friendly material. Very rarely do we have associated inflammation. Very rarely do we have a negative tissue response to the material itself. The second thing about the tissue is how thick it is. The thicker the tissue, the less relevant the color of the submucosal components can be. But conversely, the thinner the tissue, the more important the color of the submucosal components. So zirconia really makes a difference when we have thin tissue phenotypes. The other thing about zirconia is because it can be customized, we have an opportunity to work with both direct single piece screw retention into the implant, and we have an opportunity to customize components that work with titanium bases, which are very popular. Over contouring is really a critical error. Being able to customize the shape and form of the component and mate this to 3-dimensional positioning of the implant should allow us to contour the submucosal abutment to both maximize the amount of tissue that is covering the component, and our reliance upon appropriate 3-dimensional positioning of the implant cannot be overemphasized. Being able to use zirconia, metal-free alternative, is psychologically favorable to a volume of patients that we treat these days, and I don't think we can overlook that. I think that in this short period of time, it's very little we can go into in detail, and there is a whole day of information here. But in summary, yes, I think there are distinct advantages associated with customized tooth-colored submucosal components, in this case, CAD/CAM fabricated zirconia. Thank you for spending this short period of time with me. I'll talk to you all soon.
Yes, thank you, Dean, for telling us this is in fact true. So, Eva, what is your first response before we have a look at the poll results?
Well, this is really a nice video, and Dean addressed that zirconia is tissue-friendly material, but I would add so as titanium. The literature data is accordance what Dean has shared with us, that in terms of color, all ceramic implant abutments play a role, especially in highly aesthetically demanding cases with thin tissue biotype. On the other hand, there is a new systematic review coming from Geneva team stating that implant material and configuration do not play a role in terms of papilla height, soft tissue indices, and aesthetic indices. So let's see how the audience has voted.
Yes, I've logged the vote obviously near the end of the video because then Dean reveals the answer. We see that our audience is quite unanimous, but still a little bit divided. 70% voted true, and then about 20% says false and don't know. Well, the correct answer in this case is obviously true, but yet we still have 30% of the audience who is either on the don't know or false side. Can you understand why there is this confusion?
Zirconia is really promising and fastly developing material, but we still need to remember other material options, and this is why audience probably has different opinions, but stay tuned and read the literature and we will be up to date.
Yeah, you quote a lot of science here, but the statement is specifically about the aesthetics of zirconia. Is that has to do with shine through, or what are we dealing with?
That's what I exactly told you, like tissue color-like materials such as zirconia are friendly in terms of aesthetics, especially when we have thin tissue phenotype, as Dean clearly stated. So in highly aesthetically cases with thin tissue phenotype, definitely go for zirconia abutment.
Exactly. The first takeaway from this Is It True session. Now, Eva, shall we have a look at our next question, whether we can debate and vote whether it's true or false?
I'm really looking forward to it. So Jose Nart from Barcelona, Spain, is going to answer whether it is true that we can use a 6 millimeter long implant to support a single standing molar in the maxilla.
It is true, we can restore posterior teeth using single unit 6 millimeter implants. However, as many things in science and dentistry, the answer has several conditionants that I'd like to explain to you very briefly. Now, there is stronger evidence in placing two short 6 millimeter implants together being splinted, and that even gives superiority compared to sinus lifts. For single units, I would say that the evidence is in between teeth. This means a 6 millimeter implant should not be the latest abutment, but in between teeth, a single 6 millimeter would behave better. Single 6 millimeter implants for the posterior mandible would behave probably better than 6 millimeter implants being the last and only implant. So what the evidence says coincides with my clinical experience. 6 millimeter implants splinted together can be fantastic for second premolar and first molar positions. However, single 6 millimeter implants behave very well in the long term in between teeth, but not as the latest abutment, particularly in posterior maxilla. So the answer is yes, with some conditionants as you heard.
Thank you, Jose, for sharing that this is true, but only when placed in between teeth. Eva, is this a common misunderstanding?
I actually don't think so. I love how clearly Jose presented us 3 case scenarios that are in accordance scientific data with his clinical experience. So there is evidence that two implants splinted in the posterior maxilla work superior compared to sinus flora augmentation. Jose addressed that single molar implant can work well when you have 2 adjacent teeth. The explanation lies in the fact that chewing forces are distributed among teeth as well. But last thing, it is not advisable still to use it as the last chewing unit, the single short 6 millimeter implant in the maxilla. So everything is clear, and Jose managed to tell us so much scientific and clinical information in this short period of time. Let's see whether he has convinced our audience.
Yeah, well, the audience obviously cannot change their mind, because the game is you vote first and then I log the votes until when he reveals. But that is a nice concept. Keep voting. So if you're just joining us, make sure you scan the QR code. If we look at the results are pretty clear. Majority of the people, 3/4, vote yes, this is true, which is the correct answer, if you consider the but. So we see about 1/5 of the people still thinking this is false. false? Are all these people thinking about that last molar position, or could there be another
There is this
misunderstanding?
traditional approach, Garrett, sorry for interruption, that implant needs to be longer and with higher diameter. We are definitely living new era, and this video clearly demonstrates that. There is literature data to support it too.
And just from my understanding, why is it important to go shorter and shorter?
Well, it's not always important to go shorter and shorter, but for example, in posterior maxilla, you can avoid more complicated surgical procedures such as sinus floor augmentation, and then it makes it much more relaxed and less complicated for our patients.
Exactly.
And if it is scientifically and clinically supported, then why not?
Yeah, why not? So it's basically a case or a patient that you would normally maybe send away or reject or say, well, you are up for some serious maxillofacial surgery, which can now be
schedule
helped.
for sinus floor augmentation and staged implant placement, and things could get more complicated. So this is one way, and I'm really happy that we are now clear about it.
Exactly. It's an important takeaway that you learned here first at EAO Digital Days. Is it true? We have 2 videos done, 2 more to go. So Eva, what is the next topic? And let me remind you, you can vote. So scan the QR code. I'll launch the next statement while you introduce it, Eva.
I love this one. Read carefully and vote carefully. Is it true that peri-implantitis occurs less around ceramic zirconia implants when compared to titanium implants?
I have no personal experience of ceramic implants, so my statement is based on what is available in the literature. And based on that, it is wrong that the ceramic implants present with less peri-implantitis than titanium implants. The overall success rate for 1 and 2 piece ceramic implants is in the range of 92% after 1 year. Generally, very little information is available regarding both incidence, progression, and therapy of zirconia-related peri-implantitis. We know that peri-implantitis do occur, but we have very limited data on the prevalence of peri-implantitis. It has been reported that the biofilm accumulates less on the surface of the zirconium implants. But there seems to be no differences between zirconia and titanium implants in regards of the presence of Aggregatibacter actinium comitans or P. gingivalis. And earlier this year, it was reported that the histological appearance was similar between tissue samples taken from advanced peri-implantitis disease at zirconia implants and titanium implants. So, to conclude, much more data is needed before we can claim that zirconia implants present less peri-implantitis than implants made out of titanium. And until that, I think we have to say that we have no data available to make the claim that ceramic implants present less peri-implantitis compared with titanium implants. Thank you for listening.
Thank you, Professor Stefan Renvert, for showing us that this statement is false, or is it? But at least based on the current available scientific literature. Now, Eva, I feel that this statement combines everything I've heard in an EAO Congress in the last few years. It's the battle between ceramics and titanium. It's peri-implantitis. Do we know how it works, yes or no? What is your first reaction to this statement?
Well, actually, I'm more than happy, and I have to tell you that who better than Professor Stefan Renvert would be a candidate for replying this complex question. Because you know what? You have been listening about ceramic implants in EAO conferences. You have been reading about this. We have been seeing lots of Facebook, Instagram posts. This is a novel and, let's say, popular implant material. But we don't have literature data on its long-term behavior. Firstly, it has been started with one-piece zirconia implants, which means that you have implant and abutment all in one, and you need to restore it immediately, so it needs to be perfectly placed, perfectly restored with a cement. So how can you claim that cement-retained restoration shows no risks for peri-implantitis development? First thing. Second thing, as Professor Renvert says, there's no literature data on the clinical features of peri-implantitis around zirconium implants. This is really important. When you go through the literature, you cannot find, other than case presentations or case series, you cannot find serious studies talking about peri-implantitis in zirconium implants around them. And
why is that, Eva? Just because it's all too new? The studies have not been there yet?
It's quite new material, and it's maybe a little bit highly promoted. We need time, but we need to start performing these studies. And I need to tell you something else. There is a definition from biology and physiology. Biofilm, bacteria, they inhabit hard surfaces. So it is also logical to assume that they will inhabit surface of zirconia as well. And as Professor
regardless, you say that is the same whether it's titanium or zirconia.
It is just an assumption from the biology. But as Professor Renvert said, on histological samples of advanced peri-implantitis lesions around zirconium implants, periopathogens, aggressive periopathogens such as Aggregatibacter actinobincetum comitans and P. gingivalis were isolated. So we really need to take care and take into consideration that we have no literature data, not enough clinical experience and evidence, and we need to be careful. Peri-implantitis is a huge topic. You have noticed that.
Yeah.
We have been talking about implant-related complications for years now, and peri-implantitis around zirconium implant is an unknown field. So, of course, it is not true that zirconium implants present less risk for peri-implantitis development, and of course, we need studies on this.
Exactly. Now let's look at the poll results. We see that the audience is quite in line with what Professor Renvert has shown us. Most people vote false. The motive why they vote false, we have to check out in the chat as well. But still, that means that 1/3 of our audience, half of them say it's true. So apparently this is something that goes around in the world. And the other half of the people who don't vote false says, well, I don't know. This is an unknown territory for me.
I remember the session chaired by President of EAO, Dr. Cordaro, a couple of years ago, when they were discussing zirconium and titanium implants. And people usually go, even patients, go for zirconium implants from some holistic reasons. The truth is that we don't have data. Those from our friends from our audience that voted true are not supported by evidence from the literature, and those replies cannot be confirmed. It is just based on the information, and it has not been checked, done, to be sure that it is true. So it's not true.
So basically, we can conclude that this topic, this statement, is the essence of this Is It True session. Because you say it's been being shared on social media, it's been shown, people report cases where they claim this is happening, but science is not there.
I wouldn't conclude that before we go to our last video, but I would conclude that there is no literature data that claims that there is less peri-implantitis around zirconium implants.
Exactly. So stay tuned, because this is even getting better. If you're just joining us, we're going to vote again on the next statement, and you do that by scanning the QR code, which takes you straight into our Slido web application, where you see now coming up the next statement that we're going to watch the video on. What is the topic, and who will present it, Eva?
Dear colleagues, please tell us, what do you think? Is it true that socket shield technique works? And let's see what Professor Stephen Chu has to say on it.
Now, socket shield has been around since 2010 with Marcus Hertzler's group, and a lot of people over the years have actually employed and used socket shield. So is it true that clinicians have employed socket shield in the practice? And the answer is definitely yes. However, if you read the literature, there's really not a lot of information and good controlled clinical trials, randomized trials that actually look at the outcomes, either short, midterm, or long-term in regards to the benefits of socket shield. Really comparative studies. We really need to have some good comparative studies in that regard. There is a short-term 6-month study that compares socket shield with just extracting a tooth and placing an implant from a Middle Eastern group and just making it temporary. By today's standards, we really wouldn't do that, because if we extracted a tooth and placed an implant, we would most likely place a graft in the socket to maintain ridge volume and shape. So that study is a very short-term study. They did show that the socket shield did make an improvement after 6 months. I think even longer it'll show that it's actually true, again, because the control group was just placing an implant without internal socket grafting, and the test group being the socket shield group, but not grafting between the implant and the shield. We obviously need much more information in this area. We don't even have long-term studies that look at tooth extraction, implant placement, internal socket grafting with the temporary. Some of the longest studies on immediate tooth replacement have been from Jadidi, but Marco didn't actually do internal socket grafting. He just placed implants, and he then placed a temporary restoration. He had 7-year follow-up on some of these cases, and another group from Europe actually looked at tooth extraction with implant placement, internal socket grafting, but no temporization. And that is something we don't do as well. We all know that internal socket grafting does benefit. However, if I really talk to my colleagues who are really experienced surgeons, people who I admire and trust, they tell me that socket shield really works really well. So there is truth in what those clinicians who are highly skilled are doing with socket shield. And I think one of the key elements to understand is that socket shield takes much more time and is really for the highly skilled or highly trained surgeons. So with that, I'd like to conclude and say, there's not a lot of scientific evidence. However, is it true that clinicians are using this technique and enjoying good results? The answer is absolutely yes. But if you are going to do it, please do the training, learn how to do it properly. It's not for novice surgeons, and even for experienced surgeons, it does require technique and learning.
Yes, thank you, Stefan Chu, for sharing your knowledge all the way from New York. I must say, Eva, at this point, I'm a little bit confused. He ends with, yes, it's true, but, and then a very few big buts come up. What would you vote? Is it true or not?
Well, you know, it is definitely true according to the Facebook evidence, and it is even true according to the Instagram evidence. So on that field, it is 100% true. But if we listen carefully to Stefan Chu's lecture, we could draw out some data. But as I stated that it is true according to the Facebook and Instagram evidence, could you please show me our votes?
Exactly. Well, the audience has voted massively, biggest vote so far, and we see they're they're pretty undivided actually. 80% says it's true, and then there's 10% saying it's false, and another 12% honestly stating, well, I actually don't know. Now, we had to decide beforehand which one do we mark green to be the correct answer, and in the end, you told me we should go for don't know. Why is that?
You see, why I was stating Facebook and Instagram evidence, we are living the social media era, and we need to share our cases to get to know colleagues, and it is really good thing. But what I don't support personally is that sharing scientifically unsupported evidence gets to the result that 80% of our audience votes, is it true? And I'm sure that they're voting this because of the social media impact. I might be wrong, but this is how the things work.
There could also be a few theorists in our audience who say, well, theoretically, it is true, it works in the hands of some. We will hear that more throughout the digital days. What do you think about that? That we discuss either techniques or protocols that we say, well, it could work, but not for everyone?
Well, We have listened to Stephen Chu's lecture, and he nicely and clearly described it. First of all, there is a lack of scientific evidence. The state-of-the-art protocol for immediate implant placement in the aesthetic zone is still immediate implant placement with internal socket grafting and temporarization. So in order to claim that socket shield technique works or is superior or is to replace the state-of-the-art, we need comparative studies. And that is a really clear point that Stephen Chu made.
Yeah.
What he added as well, and what was your question, if I recall well, is that it works in hands of someone. I think that we shouldn't be talking about techniques that only work in hands of someone, even more if we're talking about Facebook and Instagram evidence. Because if it only works in hands of someone, that should be reserved for highly trained and highly experienced implant surgeons. Therefore, I would also like to address, of course, it probably works in the hands of highly trained and highly skilled and experienced surgeons. But it is also a matter of case selection. You know, socket shield technique basically means that you leave the part of the tooth. So if you leave the part of an infected tooth, it won't work. It will work only if you leave long enough and healthy part of the tooth. So it lowers up the indications. It might mean that only in really long, healthy roots, in cases in which vertical root fracture occurred, it might work. But to come back to the point, we don't have scientific evidence for that. And therefore, we need to be careful reading Facebook and Instagram evidence, although I
But
like...
we are now on the digital days, Eva.
No, I like to scroll, I do it all the time, I like to learn something, there is really nice content out there, but we have to be careful. You need to read the literature as well.
Very clear warning here at the end of Is It True? And I guess the biggest problem of the statement is the genericness of it. The socket shield technique works in every case, no. In every dentist's hands, no. So these are all the limitations, even if we would get the scientific evidence in a few years.
Stephen Chu said, we need to stick to the state of the art until we get the proof. And if we talk about socket shield, proper case selection and longer time for the surgery, highly skilled and trained operator.
Exactly. Well, very passionate argument here, Eva. Thank you so much for being my scientific co-host here and preparing so well and making sure that you actually take away the most important learnings. I see a very lively chat going on as well. So hopefully, I mean, with these micro lectures, we ignite a whole discussion, which could as well be on Facebook and Instagram.
I like the format. I think that we managed to hear many relevant information, and I'm looking forward to see how the chat is going on. And thank you, Gerrit, for hosting me.
Exactly. It's time to wrap up our session. We hope that you learned a lot. Thanks to our experts from around the world. And you will get more of these fast-paced answers in our Is It True sessions tomorrow and Thursday. Thank you, Eva, for now. See you back in about 2 hours, where we're back here for the challenge of the night.